So we are really excited. I am very lucky to be the voice of CHARYBDIS today, although behind me is a giant team of folks, and I will be crediting them in just a minute. But for those of you who haven't been following our journey, CHARYBDIS is the beginning of our understanding, and it's become the moniker for how we are approaching natural history of disease, how we are characterizing the health associated risks in your baseline disease for when you are a COVID case or maybe a suspected COVID case, and all of the work in between. And if you are newer to the community, I want to anchor you on a slide that I stole this from Patrick. We use this quite a bit. We have lots of different frameworks that we answer questions in the community. We may have questions that are about prediction, what will happen to me, or about what are the causal effects, population level effect estimation. CHARYBDIS is really squarely focused on this top box, what happened to them, just observing and describing what we see in cohorts of interest. And I also want to anchor on one more thing that is such an earmark of our community, which is fully specified reproducible studies. So everything I'm showing you today is available on our public code repository, and there are also interactive Shiny apps at data.odyssey.org. So while I may go through this quickly, all of this is here for you to play, and we really welcome collaboration because we are just skimming the surface on using this result set. What are we looking at across our data network? As of actually it's not a month ago, but this is still pretty current. We have a very large swath of collaborators coming from different care settings, both in the US, Europe, and Asia Pacific. We have over 16 million patients tested for SARS-CoV-2, 4.5 million patients diagnosed or tested positive, and a growing hospitalization cohort. This is a phenomenally powerful resource. There's a lot of information that we can describe here. And I just want to shout out to all of the data partners who have worked really, really hard to join us in this journey. We have many brand new sites. And I know that some of you have got shout outs on Twitter for joining us in your journey. But this has been a huge effort of lots of people behind us. What were our objectives when we set out to do this study? First, we simply wanted to describe the baseline demographics and clinical characteristics of people who have COVID-19 overall, and then stratify them by sex, age, and specific comorbidities. At the time, we also thought that creating a flu comparator would be a good idea because it wasn't just another flu. And so a secondary objective was to characterize the characteristics and outcomes of a flu cohort. And in this case, we chose between September 2017 and April 2018. Why did we go about creating this study? There were many, many studies that were published to characterize COVID-19, but there are a variety of different issues that come up as you look across the literature. Some were small sample sizes. Often cases were only in very specific countries where data had been curated. There was differences in the granularity of information available. And of course, different settings of care had different information reported. So we had a lot of questions about, did a single center's findings, would they replicate into other care settings or other countries? It really led us to this idea of thinking about, well, who gets tested, infected, and hospitalized? How can we describe that around age and gender? What are the most frequent comorbidities that they'd face? What is their treatment history if we can see it? Of course, we're really interested in knowing the symptoms and outcomes of what happens once they are diagnosed. And where we could, we wanted to try to figure out, how is COVID-19 different from the flu? And we thought about this across the patient trajectory. We thought about how we could capture information about the presentation of symptoms, how we could characterize around people who are tested, people who do get qualitative results or a diagnosis code, and then become more severe cases. And underneath that all, we could describe things like their conditions and drugs and health service utilization. And this led us to create what you'll hear a lot in Odyssey, our target cohorts. These are the people we were looking for in the analysis. And we have a number of definitions we created that were COVID-19 specific. And then we also created a number of flu definitions. And you might say, why did we create so many? Well, there were a lot of questions, and there still are, about the right definition depending on the type of question you're asking. So we might only want to look for people who have a lab confirmed measurement, or we might want to look for people who have that U07.1 code. And that's what these really represent, is different preferences and how people are defining those phenotypes. And of course, different ways to look at severity, which is in itself also part of our outcome definitions. This is the library of target cohorts we began with. They are not perfect, and actually one of the best things we are looking forward to is being able to recapitulate these and to play around with our logic. And we also set out to define a number of stratification factors, not just who gets COVID or who gets flu, but what about within people who have a history of asthma or active asthma? Maybe they're moderate to severe. What about prior cancer or cardiac liabilities and stage renal disease? There were a variety of different stratification factors that our phenotype team worked on. And this is just a sampling of different definitions that they worked through. And it's important to understand the reason we separate these, and one's on one side and one's on the other. As we go from study to study, we want consistency in our phenotypes. And thank you to Gautam Rao and to Aza and the whole team who've been helping us put more rigor into our phenotype library. Their effort here is really foundational to what we've been able to do as a team. And so today, where we are is we have had the opportunity to create a study package where we are describing these target cohorts. We have stratified on a variety of different parameters, whether it's follow-up time, your age, your index when you were diagnosed, if you have those comorbidities we were looking for. And we have a massive study result set that's available now on our website. And what's really, really cool about this is that it's not static. So even though we are about to submit a manuscript and kind of wrap up 1.0, one of the coolest things about this result set is that it will continue to live and grow. In fact, I know some collaborators who are working through data quality checks because they observed, oh, I need to go back and look at my ETL for this specific endpoint. So this is the best place to find our most current information within this study. And what's really neat about it is that you will see there's a variety of databases represented here. And if you're interested in learning how to use this Shiny app, please reach out. We'd be happy to walk you through it. There are also some teams, I know Maura and the Women of OHDSI have spent a lot of time teaching folks how to utilize this web app. You can download and create CSVs and kind of create your own result sets off of it. But it's really, really cool. And so I am not going to be able to cover everything we ever kind of accomplished in our study here. Today, I want to just give you the highlights, which is there are 12 manuscripts that are actively under review that I know of, and I think there are more than this number. These represent different populations of interest, like our pregnancy cohort, our pediatrics cohort. We have the asthma COPD cohort. We have folks who are looking at just testing strategies. There is a lot of information available. All of these have preprints if you're interested in seeing where we've started on these topics. There are 16 validated COVID-19 phenotypes summarizing the testing variations, the diagnosis codes in use, how to look at hospitalization, and even the sticky piece of how to look at intensive care, which is a really tricky thing to look at across different care settings. And of course, in addition to that, there are more than 85 validated comorbidity phenotypes that you could use in your study packages. So a wealth of knowledge that anyone could take advantage of. And these are available both in SQL as well as JSON format. I can show you how to use them in your atlas. All of this is out there and things that we really want the community to tap into. Where are we going? So we've started to describe the first wave, and a lot of our results are through about the middle of last year. So September, October is where a lot of the results kind of taper off. As we look at 2.0, we are thinking about things like long-term COVID. We're also going back and going to update and amend the protocol to have more follow-up time. We may have naively thought that 30 days was enough time, people would recover. Well, now we know we need to add more windows of time. We've also had great discussions. I know Talita and Danny had a breakout session at the symposium last fall where they talked through some of these topics about maybe finding ways to work with other data feeds. Non-pharmacologic interventions is going to be a subgroup that we'll meet and discuss. And there's definitely some groups coming to us looking for the OHDSI community to provide direction there. We are looking across different socioeconomic factors. We're thinking about updating some of these cohort definitions for these stratum to be more robust. And of course, within certain subgroups, there's been requests to maybe further delineate. So in our oncology work, we're going to go back and add more types of cancer. We are going to try our best to figure out ways to look at treatment status and history. I know for respiratory disease, we've been talking about ways to be more granular there, or even in autoimmune, how could we break it down further? So we have a lot of work cut out for us. There's a lot of great information we've received from the reviewers that have looked at our manuscripts. We are actively kind of cycling through and trying to improve as we go. And we're really, really excited because even though we have finished all this great work and we're about to close the door on 1.0, 2.0 leaves us the road ahead to have a lot more exploration, and we invite you to join us on that journey. And of course, you guys know I'm not the only monster. There are lots of other monsters in our ecosystem here, and SCYLLA is going to be a great counterpart to CHARYBDIS, and that's where Dania is going to pick up in just a moment. Before I do that, I just want to thank Talita and Albert and the whole team behind us. There really has been a Herculean effort to organize this massive data network, to validate these phenotypes, and to begin to produce this body of evidence. So I'd be nothing without their help. So thank you all so much.